Thank you very much. So the next speaker is Dr. Randall Bateman, and he will talk on imaging and biomarkers. Randall, please.
Okay, shown here are my disclosures. I'm going to be presenting the imaging and the biomarker results from the ClarityAD study of Lecamenad. As part of the Lecanemab's development, there are a number of ways in which biomarkers are used, and that includes in patient selection, for example, in the ClarityAD study with amyloid PET or CSF 42 to 40, and the prevention studies, for example, AHEAD 345 using blood plasma 42 to 40. Measuring the target engagement and pharmacodynamic measures, we saw the results, the top-line results of amyloid PET, and also the CSF and plasma measures for amyloid beta 42 to 40, and in development is a protofibrillar assay. And in order to measure the pathophysiology of the disease and the pathology that exists in the brain, there's a number of different measures, including PET scans, amyloid and tau PET, as well as CSF and plasma amyloid measures, tau measures, measures of synaptic function and astrocyte function, and then more traditional measures of brain volume by MRI. And finally, the clinical measures were already reviewed, and I'll put that in context to these biomarkers. Shown here are the various measures that were performed in the trial. We're going to be reporting on all of these measures, as well as the way they're measured, shown in the footnotes here. The amyloid biomarkers are shown on this slide for the soluble measures. You see on the top two graphs, the cerebrospinal fluid amyloid beta 42 and the cerebrospinal fluid amyloid beta 42 to 40 ratio. And the bottom left is the cerebrospinal fluid amyloid beta 40 measures. What you'll note is that lecanemab had no effect on amyloid beta soluble levels for A beta 40. However, significantly increased the values of CSF amyloid beta 42 at 12 and 18 months. Correspondingly, in the top right graph, you see the 42 to 40 ratio also improve at 12 and 18 months, and the corresponding plasma amyloid beta 42 to 40 ratios in the bottom right. Overall, this indicates early and sustained amyloid reversal effects and likely slowing the process of aggregation of amyloid beta in the central nervous system. Shown here is the amyloid PET graph that was reviewed before. I'll make a few other points here. One is that the population that came into the study had centiloid levels of around 75 to 77. And already at 3 months, there was a substantial drop of 20 centiloids towards normal. By 6 months, the drop was closer to 35 centiloids. And by 1 year, the drop was 50 centiloids, putting them close to the threshold of cutoff. By the end of the study at 18 months, a further drop was seen, and you can see the percent of amyloid negative, the people who fell below the amyloid cutoff of 30 centiloids in the bottom table. You can see that percent increase so that by 1 year, most people, 54%, were amyloid negative by a quantitative cutoff, and by 18 months, 2/3 of the people were amyloid negative. Shown on the right, placebo and lecanemab values for representative individuals at baseline and 18 months are the images where you can see the relative reduction of amyloid removal in this trial. For the tau biomarkers, they're both soluble measures of tau in CSF and plasma, as well as insoluble measures by tau PET. These measure two different kinds of tau processes. One is a phosphorylation of soluble N-terminal to mid-domain tau that seems to be a response to amyloid plaques and a marker of early tau pathology. You can see the changes here over time, that as people progress in their disease, they tend to increase their soluble levels of phospho-tau 181, both in the CSF and the plasma. But with treatment at 1 year and at 18 months, you see substantial declines of soluble phospho-tau 181 towards normal. And so there's a large delta here throughout the time course, both in CSF and plasma, and that this indicates that the downstream pathophysiology of removing amyloid changes the response that the brain has in phosphorylating tau. Tau PET is another measure of tau. This measures a different form of tau that's aggregated in the brain, and it's largely comprised of the microtubule binding region in the brain in the form of neurofibrillary tangles and dystrophic neurites. The different regions were measured in this study, and a comparison across all regions was done in a pre-specified way to look at the changes. Although there were trends in most regions of less tau accumulation over time, it was the temporal lobe in this study that reached significant levels of less tau accumulation, and that's shown on the right in the medial temporal, the metatemporal, and the full temporal lobe on the right. So this data indicates that in certain regions of the brain, notably the temporal lobe and suggestive changes in other areas, that the accumulation of tau pathology over time with amyloid removal is blunted and slowed. This is quite important because in Alzheimer's disease, we define the disease as plaques, tangles, and dementia, and two of these pathologies have been slowed or reversed. The neurodegeneration markers are shown here. This includes characterization of cerebrospinal fluid and plasma neurofilament light chain, as well as cerebrospinal fluid total tau levels. Similar to the phospho-tau levels, you see total tau increases over time as the disease progresses, but with amyloid removal with lecanemab, you see decreases in the amount of total tau in the CSF at 12 and 18 months that are highly significant. Neurofilament was not significant in the differences, although there was some trends noticed in the plasma NFL towards 18 months. Subsequent follow-up will be needed in order to determine if this is a sustained or a robust effect. And finally, for the soluble measures, we have astrocytic and synaptic biomarkers of the disease process. More recently, activated astrocytosis and the secretion of glial fibrillary associated protein, GFAP, has been shown to be an accurate measure of disease progression. And you see that here during the trial. Plasma GFAP is increased and stays sustained throughout the trial, but with treatment with lecanemab, a reversal is seen and plasma GFAP lowers at highly significant levels at 6, 12, and 18 months. Similarly, for a synaptic measure, neurogranin, you see the CSF neurogranin levels are largely stable during the trial, although these are altered at high levels. And over time, that also lowers towards normal at 12 and 18 months in a significant way. Finally, the volumetric MRI measures of atrophy are shown here. Representative areas, including whole brain volume, cortical thickness, and lateral ventricular volumes are shown on the top panels, while the hippocampal areas are shown on the bottom areas. Across the brain in general, increased atrophy was seen during treatment with lecanemab at 6, 12, and 18 months for whole brain, cortical thickness, and ventricular volumes. In contrast, the hippocampal volumes did not show that same increased atrophy and actually were significantly less atrophied by the end of the trial at 18 months. So now I'm going to discuss my interpretation of these results. Lecanemab has impacted various measures in CSF plasma and imaging biomarkers of Alzheimer's disease pathology and pathophysiology in the domains of amyloid, tau, neurodegeneration, astrocyte, and synaptic pathophysiological measures. Lecanemab had beneficial effects on a multitude of these biomarkers, including the amyloid, tau, and other pathophysiology measures. The neurodegeneration markers of NFL and the volumetric MRI gave a mixed picture, potentially because these measures may take more time to respond. They may be compounded by having amyloid removal and will be followed in ongoing studies. The drug directly removed amyloid plaques is measured by soluble and amyloid PET measures, It also had downstream effects on tau pathology as measured by PET, soluble measures of tau pathophysiology in the CSF and the blood, synaptic dysfunction, and astrocyte activation. I believe that these findings do indicate a biological disease modification by improving the amount of amyloid and tau pathology during and the course of the disease, while also impacting the pathophysiology of Alzheimer's disease. Disease modification is further supported by the clinical benefits shown in cognitive and functional scales, and also the phase 2 data, where it was shown that during a gap period, the benefit is sustained during that time. This will be further explored in the ongoing open label extension with biomarkers, clinical and cognitive measures to better understand the full effects of lecanemab. Thank you.